Hello! I would like to express my gratitude to the surgeons, anesthesiologists, intensivists, and clinical researchers for your dedication to kidney transplantation. Today, we will discuss fluid selection and administration strategies for kidney transplant patients.
大家好，我要向致力于肾脏移植工作的外科医师、麻醉科医师、重症医学科医师及临床研究人员表达谢意。今天我们将探讨肾脏移植患者的液体选择与输注策略。
Welcome to this explainer. Now, as clinical specialists, you know all too well that whilst our surgical techniques have advanced remarkably over the years, the precise hemodynamic optimization of the transplant recipient, well, it still remains something of a black box, doesn't it? Today, we are going to unpack the data together. We're going to challenge some of those deeply entrenched old paradigms and really critically examine the modern evidence base for perioperative fluid administration. Here's our roadmap for this session. We'll start with the ESRD and delayed graft function challenge, move on to demystifying static CVP limits, look at fluid types and volume strategies, dive into goal-directed therapy data, explore dynamic indices like PPV and SVV, and finally, synthesize it all into an actionable clinical protocol. It's a lot of ground to cover, so let's jump right in. Section 1, the ESRD and DGF challenge. This is where we set our physiological canvas. To truly understand the stakes of our fluid strategies, we've got to first acknowledge the unique, often perilous physiological canvas of the kidney transplant recipient. We all know that patients with end-stage renal disease present an extraordinary challenge. We're talking about a baseline physiology that frequently includes uncontrolled hypertension, concentric left ventricular hypertrophy, dilated cardiomyopathy, and profound electrolyte imbalances. They are essentially oscillating precariously on a razor's edge between hypovolemia and hypervolemia with a shockingly narrow safety margin. If you take a look at this timeline from the Fernandez review, you can visualize the critical window for intervention. Notice delayed graft function, or DGF, which is universally defined as the need for dialysis therapy within the first week following transplantation. It casts a long looming shadow over the entire postoperative course. Look at how perioperative fluid management is heavily concentrated in those crucial first 24 hours. The split-second interventions we make here, monitoring cardiac output, manipulating stroke volume, and central venous pressure, they directly dictate the survival trajectory of the graft long before diagnostic tools like ultrasound or biopsy even come into play at D7. And look, the statistics surrounding DGF are, quite frankly, sobering. We are looking at an incidence rate of 30 to 50% in deceased donor kidney recipients. And that's a number that is only rising as we increasingly and necessarily rely on extended criteria and donation after cardiac death organs. But the true danger? It lies in its compounding effect. Think of it as a domino effect. When a patient experiences both DGF and acute rejection, the estimated rate of graft survival at 5 years plummets to roughly 35%. To put that into perspective, that is an 8-fold higher risk of graft failure compared to patients without these risk factors. So preventing DGF is absolutely not just about avoiding a few rounds of immediate dialysis. It is quite literally the ultimate determinant of long-term graft survival. Right, moving on to Section 2, demystifying static CVP limits. It's time to rethink our old targets. For decades, central venous pressure has been the undisputed North Star guiding fluid management in kidney transplantation. We were all taught to push fluids to maximize CVP, weren't we? But it is high time we subject this historical reliance to some rigorous critical evaluation. Guided by excellent narrative reviews, like the one by Schnuele and van der Wood, we see the data actually paints a highly nuanced picture. Retrospective cohorts show us that a low emergent CVP, specifically anything under 8 millimeters of mercury, is indeed a significant predictor of delayed graft function due to hypoperfusion. But here is the catch. Conversely, driving CVP too high is equally destructive. A mean CVP of 11 millimeters of mercury or greater is an independent risk factor for chronic graft dysfunction and failure. The evidence is crystal clear. Static CVP correlates poorly with actual intravascular volume and fluid responsiveness. It's like trying to guess how full a balloon is just by measuring the pressure of the air outside of it. Instead of chasing these arbitrary CVP numbers, maintaining a mean arterial pressure, or MAP, between 70 and 100 millimeters of mercury provides a far more reliable, physiologically sound baseline for renal microcirculation.
So we really must completely abandon the old adage of maximal volume infusion to the point of no further fluid responsiveness. Let's actually look at the pathophysiology of what happens when we do that. When you aggressively load fluids beyond the heart's position on the Starling curve, the cardiac output doesn't increase. The heart says, I'm full. Instead, this immense hydrostatic pressure physically shears and damages the endothelial glycocalyx. Think of the glycocalyx as the delicate, protective, non-stick coating on the inner lining of the vasculature. Once that barrier is breached, the fluid relentlessly shifts out of the vessels and into the third space. You end up with a devastating paradox. You are pouring in volume, thinking you're doing the right thing, but the patient develops interstitial tissue edema, delayed graft recovery due to cellular hypoxemia, and potentially catastrophic non-cardiogenic pulmonary edema. You are literally drowning the tissues to chase a number on a monitor.
Which brings us nicely to Section 3, Fluid Types and Volume Strategies. Let's look at evidence-based selection. Moving from how we monitor volume to what we are actually infusing, because the choice of fluid is just as vital as the volume delivered. Let's examine the evidence based on the American Society of Anesthesiologists Committee on Transplant Anesthesia Consensus Statement. The consensus is absolutely definitive. Balanced crystalloids, such as lactated ringers or plasmolite, are the superior choice. Now, historically, there was a massive fear that lactated ringers would cause hyperkalemia in anuric patients, right? We've all heard that. But the data actually shows the exact opposite. It reduces the risk of hyperkalemia and acidosis compared to the massive chloride load you get from 0.9% normal saline, which reliably induces hyperchloremic metabolic acidosis. Furthermore, synthetic colloids like hydroxyethyl starch, or HES, must be strictly avoided. They are unequivocally linked to an increased risk of acute kidney injury. Don't use them. Albumin can be used safely if the patient is severely hypoalbuminemic, but it really offers no general advantage over balanced crystalloids. And crucially, the routine use of renal dose dopamine or high-dose diuretics, completely clinically obsolete. Oh, and mannitol just prior to reperfusion, it does have some limited evidence suggesting it might reduce the need for dialysis, but it's not a magic bullet. Okay, so we know what fluid to give, but what about total volume? A landmark 2021 retrospective cohort study by Harbell and colleagues at the Mayo Clinic looked at 1,171 patients. That's a huge sample size. They divided them into a restrictive strategy, meaning under 3 liters total, and a liberal strategy, meaning 3 liters or more. The findings were quite literally paradigm shifting. There was absolutely no significant difference in the rates of delayed graft function between the two groups. What this proves is that massive fluid loading is simply not a prerequisite for graft survival. As long as you are diligently maintaining adequate mean arterial pressure and avoiding profound hypovolemia, a restrictive strategy is entirely viable. Better yet, it completely spares the patient the nasty morbidities of volume overload, leading to shorter ICU stays and fewer pulmonary complications. Section 4, Goal-Directed Therapy Data. Optimizing stroke volume. This realization about fluid volumes has ushered in a completely new era in transplant anesthesia, goal-directed therapy, or GDT. Rather than relying on those static pressures or arbitrary volume targets we just discussed, GDT focuses on dynamic stroke volume optimization. But we have to look impartially at what is probably the most intellectually tense question in our field today. We know GDT improves outcomes in major abdominal surgery, sure. But does stroke volume optimization definitively reduce delayed graft function in the highly unique setting of kidney transplantation? Let's unpack the mixed evidence.
While the literature is intensely divided, it's a bit of a mixed bag, isn't it? On the positive side, Cavallari's prospective study of 66 patients showed a really striking reduction in DGF. It dropped all the way down to 12% from 32%, and significantly fewer cardiovascular complications when using stroke volume optimization. That sounds fantastic. However, other robust trials severely temper this enthusiasm. Harbella's esophageal Doppler study proved the concept was feasible, but it failed to show any difference in DGF rates. Furthermore, a recent systematic review and meta-analysis by Klonarakis, which pulled 4 RCTs of 205 patients, found absolutely no significant impact on DGF whatsoever, citing very low-grade evidence. And most recently, the LOTSI multicenter RCT using non-invasive pulse contour analysis, the ClearSight monitor on 181 patients showed absolute clinical equivalence to conventional therapy regarding DGF, graft loss, and ICU stays. So what's the takeaway here? GTT is excellent for managing cardiovascular stability in our high-risk patients, absolutely. But we currently lack high-quality evidence linking it strictly to the eradication of DGF itself.
Moving on to Section 5, Dynamic Indices, specifically PVV and SVV, and how they predict fluid response. Since the broader concept of goal-directed therapy yields mixed results on DGF, let us drill down into the specific dynamic indices that actually drive it: pulse pressure variation, or PPV, and stroke volume variation, or SVV. How do these tools perform when compared head-to-head against traditional CVP? This algorithm brilliantly illustrates the protocol from the Goyle randomized controlled trial. They took 75 chronic kidney disease patients and split them into 2 arms.
Group A was guided by CVP, targeting 10 to 15 millimeters of mercury. Group B, however, was guided dynamically by PPV, targeting a very narrow window of 10 to 13%. The logic is simple but elegant. If PPV crept above 13%, indicating the heart was highly fluid responsive during mechanical ventilation, a 200 ml fluid bolus was given. If PPV dropped below 10%, indicating the heart was no longer responsive to volume, fluids were immediately halted. And the outcomes of this targeted approach were highly revealing. The PPV-guided group required significantly less fluid prior to graft reperfusion compared to the CVP group. By actively avoiding the pursuit of arbitrary static pressures, the PPV group suffered significantly less postoperative tissue edema and actually showed lower markers of anaerobic metabolism, specifically serum lactate. Now, while the ultimate rates of DGF didn't reach statistical significance, largely due to the trial's small size, though it's worth noting the only case of DGF occurred in the CVP group, the dynamic PPV approach demonstrated clear, undeniable clinical superiority in reducing those secondary volume-related morbidities.
However, we must impartially add some nuance to this discussion. A separate trial by Decassi compared a PPV-guided strategy using a greater than 12% threshold against a strictly monitored liberal protocol delivering a steady 10 mL per kilo per hour. Interestingly, they found complete clinical equivalence across all major functional markers. Total urine output, uremia clearance, and creatinine trajectory were identical between the two groups. This teaches us a really important lesson. Dynamic indices are a highly robust, incredibly safe way to tailor therapy and avoid the dangerous extremes of hypervolemia. But a thoughtfully applied, closely monitored baseline infusion is not universally harmful either. The true enemy here isn't a steady infusion. The enemy is unmonitored, reactive fluid overloading.
Finally, Section 6, Clinical Protocol and Future Directions. Synthesizing all of this evidence. So how on earth do we synthesize this massive wealth of conflicting trial data, physiological theory, and monitoring technology into a unified, actionable approach for the operating room? First, we must anchor our practice in strict definitions as outlined by Fernandez and colleagues. We are always aiming for euvolemia, which, as we've established, is a razor-thin margin in ESRD patients. Our decisions simply must be based on fluid responsiveness, the physiological ability of the patient's heart to actually increase stroke volume by more than 10% in response to a fluid bolus. We are aggressively avoiding fluid overload, which shreds the glycocalyx and causes edema, just as vigorously as we are avoiding hypovolemia, which guarantees ischemic reperfusion injury to that precious new graft. To achieve this delicate balance, you need the right tools. Here is a highly concentrated matrix of your monitoring modalities. Traditional CVP and MAP are cheap and ubiquitous, and while MAP is absolutely essential for ensuring perfusion pressure, static CVP is a very poor predictor of fluid responsiveness. Pulse pressure and stroke volume variation are your gold standards for dynamic fluid responsiveness. The caveat, they require the patient to be mechanically ventilated with a closed chest, which is fine intraoperatively but limits them post-op. Esophageal Doppler provides excellent direct blood flow velocity data in real time, but is highly operator-dependent and requires constant probe repositioning. Finally, novel non-invasive pulse contour technologies like ClearSight are emerging to provide continuous GDT. Though, as the Lacey trial showed us, their accuracy can be seriously compromised in patients with the severe, calcified vascular disease that is so typical of ESRD. Based on the totality of the evidence we've reviewed today, here is your step-by-step, actionable, evidence-based protocol. Step 1. Perform a meticulous baseline assessment. Look at their pre-op weight, their recent dialysis volume, and their cardiac history. Initiate a modest baseline maintenance infusion of a balanced crystalloid, such as plasmolite, at around 5 mL per kilo per hour. Step 2. Defend the mean arterial pressure. Keep it strictly between 70 and 100 millimeters of mercury to ensure renal autoregulation. And don't be afraid to use judicious infusions of targeted norepinephrine to maintain that perfusion pressure. Step 3. Apply your dynamic indices. Give small 200 to 250 ml fluid boluses only when PPV exceeds 12 to 13% and stop immediately when it drops below 10%. Finally, Step 4. Execute a tailored reperfusion strategy. We all know massive vasodilation occurs upon clamp release. Anticipate it. Manage it with vasopressors to optimize MAP prior to clamp release rather than prophylactically blindly drowning the patient in crystalloid beforehand. Crucially, this protocol is not a one-size-fits-all. It must be adapted for your highest risk cohorts. For patients with severe myocardiopathy, the heart simply cannot handle volume. You must strictly avoid fluid loading, rely heavily on vasopressors and inotropes to defend the MAP, and accept lower PPV thresholds. For those with pulmonary hypertension, the right ventricle will fail catastrophically if overloaded.
In these cases, invasive monitoring like a pulmonary artery catheter or transesophageal echocardiography is entirely justified and recommended. And for the patient who arrives already volume overloaded, perhaps they missed their last dialysis session, restrict your baseline fluid severely to less than 3 mL per kilo per hour. Use your dynamic indices purely to confirm that the patient is, in fact, not fluid responsive. Individualized care here is paramount.
We have certainly moved from the dark era of blind, static CVP targets to the precision of dynamic stroke volume variation. But as we have seen from the conflicting data today, even our absolute best macro-hemodynamic tools don't always perfectly predict microvascular graft recovery. So, as we look to the future, we have to ask, will emerging technologies like continuous non-invasive bioimpedance and direct microvascular tissue oximetry finally close this evidence gap? Will we soon be able to look beyond the central circulation and directly monitor the perfusion of the graft itself in real time? That is undoubtedly the next exciting frontier in kidney transplantation. Thank you so much for joining this thorough exploration of the evidence, and I hope this serves your clinical practice well.